Discussion. If there's something that you don't understand or you have a question about and you think you might forget about it later, I don't mind being interrupted. I get that at home all the time, so here is no difference. So if you have any questions, don't hesitate. But anyway, what we're gonna try to discuss and kind of give you a better understanding of is fall risks. I think is the big thing that we're looking at, and how does the regional technique that we're using back there affect the potential for falls over here and upstairs. So a number of the ones that we're going to be looking at today, probably the only ones today, are the lower extremity blocks. Out of all those lower extremity blocks, there's 4 of them. Only one of them really involves just the sensory, doesn't affect the motor. So, and we'll go over that one, and they're pushing more towards that for total knees and things like that. The problem with that particular block is it's not as strong of a block as some of the other ones, so you're going to see a little bit more higher pain scores over here because of that. But yet it doesn't affect the motor control, which is what they want upstairs. So anyway, the different blocks that we do for lower extremities are a popliteal block, which is part of the sciatic nerve. We do an adductor canal block, which is the one that's only purely sensory. Occasionally it can grab the motor, but most of the time it's purely sensory. Then we do a femoral nerve block, which is motor and sensory. And then I'm probably one of the few that does blocks for total hips and hip scopes and things like that, and that's something called a fascioliaca block, which is another term for that is a 3-in-1 block, which grabs all the nerves that go down to the hip, and it does grab the ones that go to the thigh muscles. So you can have weakness from that one also. So again, out of the 4, there's only one that's purely sensory. So what we do for like ACLs, or what I do for ACLs and total knees, things that involve most if not all of the knee, I'll do 2 blocks on that one. One of them is the popliteal block, which grabs the posterior portion of the knee. It also grabs all of the foot, anything below the knee all the way down, except for the medial malleolus. And some people have sensory distribution down to the first great toe too with that particular exclusion from that block. So in order to catch those things, you also have to do either an adductor canal block in addition to the popliteal block, or you have to do a femoral nerve block to catch the whole knee. Again, if we're going to do something below the knee, like the foot, an ankle or something like that, you can catch everything with just a popliteal block except for that inside of the ankle, the medial malleolus, and possibly the big toe. So again, if you're going to grab that, then you're going to have either the surgeon inject some local right around the site where they're going in with the screws potentially on the medial side, or you're going to have to do some other kind of major nerve block like the adductor or the femoral. And again, those will cause weakness. It's kind of obvious, the popliteal block is going to cause weakness like foot drop and things like that. So if they get up and they're trying to walk, they're going to drag their foot. And it very much depends on the concentration of the medication that we're given back there. Usually I use a fairly heavy concentration for the surgery because it takes that to get rid of a lot of the sensation, a lot of the pain. The lighter the dose, the less the concentration, the less motor block that you have. So I know a lot of you girls are out here, you're asking the patient, hey, can you move your foot? If it's had time to set in, no, they can't. If I'm using a higher concentration, if I'm using a lower concentration, then yeah, they can kind of move their foot a little bit more just because we've reduced that. And again, it depends on if we're looking for intraoperative relief, or if we're looking for more postoperative relief, or if they're going to end up with a nerve block that they're going to take home. The medicine that's in that nerve block, as you all know, is like 1/8% versus, we may give 0.5% bupivacaine back there because it's required in order to decrease the patient's ability to sense pain. So again, like the popliteal block will catch all that, it'll give you a foot drop. If we do an adductor canal block all by itself, again, that's purely sensory. That grabs the saphenous nerve, which does not have any motor function to it at all. So like I say, you're going to see us push that a little bit more for the total knees so that they can get up and around. And then the femoral nerve block is a little bit higher, and it's motor and it's sensory. And that makes the thigh muscle weak. So if they try to stand, the leg's going to buckle, even when they get upstairs afterwards. Because most of these blocks that we do, because it's around a specific major nerve root, it can last anywhere from 15 to 24 hours if you just give a single shot. Versus if you're threading a catheter, of course, it's going to last 2 to 3 days as long as the catheter stays near the nerve. And then the other one that I do is a fasciolaca for hip surgeries. It's not the best block in the world. Probably a lumbar plexus is a better block for that, but that one has too much risk. So a lot of the anesthesiologists don't do that one anymore. There's only one or two that I know that still kind of do that one. But again, it's just got too much risk for bleeding and nerve damage and things like that, so nobody really does that one. So we're willing to accept a little bit more pain and recovery, but yet be able to knock it down with the fasciolaca. But again, that grabs a femoral nerve, obturator nerve, lateral femoral cutaneous. So it's called the 3-in-1 block, and it grabs all those nerves that do have motor control. So if you get a hip that's over here that got a block, they're going to be weak too, trying to stand up. So again, you just need to ask, and you guys always do, document what kind of block that we did, and then expect that they're going to have some motor loss unless they only get the adductor. We've talked with the surgeons and with PT upstairs as to what we want to, how we want to guide things in the future for total knees specifically, because they're trying to increase the rate with which they get out of the hospital. So some of the surgeons are doing posterior capsular injection on the knee, and that's all they want. They're using Exparel, which will last 2 to 3 days because it's in a little liposome, so it slowly leaches out the local anesthetic over time. It's not going to get all their pain, but it helps it to be tolerable enough to where they can take oral medications or IV medications and still get through the postoperative period. And then some of the surgeons still want them to, when they get over here, they want them to be as comfortable as they can be. They don't really care about how mobile they are on the first or second day. They're more concerned about the pain relief. So some of my guys will have me do a pop and a femoral, and with those two blocks together, if you get a good surrounding of the nerve, they have, and you guys see it, they have very little, if any, pain over here, but when they get upstairs, they can't move around too well until maybe the second day. When the second day comes around, then they're on that lighter dose of the local anesthetic, but their goal is to try to get them up and around the first day and make them more mobile. A few of the surgeons tell me that it doesn't really seem to make a difference on their standpoint whether we use the super block, as I would call it, versus the lighter block. They still tend to get out in a couple of days. One of the other ones, when we were trying to change this over to try to see how the patients did and what their ability to move and get out of the hospital was, we had, I think it was just one patient when we first started. He took, and of course he was a chronic pain, he probably wasn't the best one to try it on, but he took so much narcotic that he ended up getting an ileus and ended up staying 5 days instead of the 2 days because the adductor canal block wasn't strong enough for him. So maybe on those patients we may switch it just a little bit if it looks like they're going to take tons and tons of narcotics or they have a history of chronic opioid abuse. Then we might use that stronger block selectively for those people. But the run-of-the-mill person who doesn't have that history, I think we're going to strive to try to use the adductor canal more, or just use the posterior capsular block just by itself. But again, you'll see a little bit more pain out here. There's just no way around it. You can't have them both, for, you know, or at least we haven't figured out anything where they could have both, you know, 90+% pain relief and the ability to move. So that's kind of where we're at. And you guys got any questions?
I had a sciatic nerve block for a knee, I think.
Yeah.
Okay, what's that rationale?
Sciatic nerve block, that's just to get the posterior aspect of the knee. It depends on where they did. The sciatic nerve runs from mid-gluteal all the way down, but depending on where you grab that nerve determines what it's called. There's no real reason to numb that nerve up here. If you want to get the back part of the knee, you can numb it in the popliteal area, and that'll do just as well. It's a little harder to get up here. It's easier to access down here. Gives you the same result and the same outcome so far as ability to move and motor control and things like that. It's no different. And it just may be that person doesn't know how to do a popliteal block for some reason, is more familiar with doing the old, that's the way we used to do them. Is up in the gluteal area, but you don't have to do that. You can catch the whole of the knee just with that popliteal block and adductor or femoral on top of that. Yeah, you don't have to mess with it.
Are we asking the right questions in recovery?
Yeah, I mean, I haven't had anybody not ask. And a lot of the times when I change up the way I block, I try to inform you guys or educate you guys, hey, you know, this patient's going to hurt a little bit because I just put it in. It takes a little bit of time to soak in, or they're going to hurt more than normal because I did a block that's not as strong. So don't expect him to get 100% relief as time goes on, because it's not going to happen. And again, the reason why we're doing that is just so that they can have better mobility upstairs. Yeah. Yeah.
How many are using the joint cocktail like in the total knees, like inside the benches?
The guys that I use, two of them are. Yeah, and they're injecting all kinds. Well, they're injecting clonidine, they're injecting gabapentin, they're injecting either ropivacaine or some other local anesthetic, and I think they're injecting Toradol and all this kind of stuff. And if you get somebody who knows how to do a posterior capsular injection, they don't need a popliteal block. That grabs all that back side of that knee. They still need something for the front side, but one of the surgeons I work with, he wants to use Exparel on his posterior capsular injection, and once you inject Exparel, I can't put a catheter, because that bupivacaine's leaching out. And I discussed that with him, and he says, well, he's used different kinds of locals, and that one works best for him, so his preference is just to use that and then just have them take narcotics out here, IV and oral pain medicines. So anybody else got any questions? And like I say, you guys should feel comfortable asking whoever's providing the anesthetic, what kind of block they gave or what you can expect from it. Did you feel like you got a good block with the ultrasound? Those kinds of things. And of course, I think everybody's doing ultrasound guided nerve blocks. Most all of them that I understand or know of, because that increases the likelihood that you're going to get a good block because you can see the nerve, versus the way we used to do it, is with just a nerve stimulator and patient participation and watching the motor response to see if you're in the right area. Yeah, and you may be close, you may not. And so it was about 80% effective with that technique, and with the ultrasound it's approaching 98+%. If you know how to use the ultrasound machine, that's the other thing. If you don't know how to use it, well then you're probably not going to get much better results. Yeah. All right. Anybody else? That was easy. Yeah, no problem. I hope that helped y'all. Yeah, you're welcome.